Well, hello everyone, and apologies for not being with you again this year, considering the current situation in the region. Hopefully, we can meet face to face next year in your wonderful event. So, I was assigned the topic of odontoid fractures by Professor Sharawi, and those are my disclosures. I consult for a few companies, I sit in the advisory board of others, but none of those are related to my presentation today. Now, it's important to highlight that a couple of months ago, we issued our book chapter in the cervical spine surgery book with the team on upper cervical trauma, including all the atlantoaxial cervical trauma. And that gave me a better understanding of such kind of injuries, particularly the most common one, which is the odontoid fracture. So let's start with the case here. This is a 59 years old female patient who was a methamphetamine addict who presented to us with motor vehicle negligence. She had severe neck pain and non-neurological deficit. And that was the kind of injuries that we would usually get at the University of Missouri. As you know, Missouri is the capital of methamphetamine in the world, basically. So she had a CT scan upon arrival, and that's how it looked like. She had a type 2/3-ish odontoid fracture. We tried to put her in a halo. Remember, she was a methamphetamine addict, so she was loaded with drugs. That's how she looked in a halo, and then we had some X-rays for her in the next morning, and I walked in the morning, and she has taken the vest off. She's just walking around with the halo without being attached to the vest, because according to her, it was making her warmer than what she wants to be. And that's, by the way, very common, right? You see a lot of patients walking around without the vest, believing that they have everything stabilized since they have those pins in their skull. Now, I'm going to come back to that later, but the problem, I think, with odontoid fracture that our population is growing, and we are anticipated by the year 2050 that almost 1 in 3 patients that we're going to operate on is going to be above the age of 65. So we're going to see more and more of those fractures in the future. And we already know very well from literature that it is the most common cervical spine fracture in the elderly above the age of 70, accounting for more than 60%. So it's something that we really need to understand. It's something that we really need to know how to deal with it. Now, everyone is familiar with the famous Anderson and Alonso paper that was published way back in the JVJS. And type 1 is basically a tip fracture, usually asymptomatic, and can be treated in a cervical collar. It's very common, though, to understand that it's very common to get missed as well. So make sure that you study those CT scans very well in order not to miss them. Type 2 is basically where the money is. It's the most common, and this is where the controversy of how to fix those lies, whether it's in conservative management versus surgery, and we're going to come to that later on as well during the presentation. Obviously, type 3 is a very benign type. The majority of the time is that one that extends into the body. And since it extends into the body, it usually has a very good healing rate with conservative management. The non-union, as you can see over there, is almost somewhere around 10%. Only those ones who have more than 5 millimeters of displacement or more than 10 degrees of angulations are the ones that end up falling into non-union. This takes me back to the famous paper by Anderson that was published in the Yellow Journal in 2010. And you can see here that for type 1 and type 3, there is basically not much of a controversy. Over there is type 2, as I said before, where the money is and where the controversy on the treatment is. So if we jump here, the same paper to type 2 on the different treatment modalities. You can see here that if you're using basically cervical orthosis or cervical collar, you have a 50% healing rate. That goes a little bit up to the 60s. If you're using a halo vest with odontoid screws, it goes all the way up to the 80s. And obviously, the best fusion that you're going to get is with the posterior C1. And I think the problem is the literature fails to describe the definition of the elderly, right? Because if you're going to run a paper on the elderly population, you're probably going to pick those patients who are over the age of 70 and call them the elderly. But we know very well as surgeons and as health practitioners that is not about the number, it's about the physiological age of the patients, because not every 75 years old patient is the same. But let's see what the literature says. So we know very well that in patients above the age of 70, their mortality rate for such fractures can go all the way up to 40, particularly if you use the halo, and we all remember that very fancy paper that described the halo in the elderly as a death sentence. We know that the risk of pneumonia is much higher in the elderly, and if you put them in a collar, you have a 50% failure rate. But the truth is, the problem is we look only at the data on odontoid fracture. If you take if you take a step back and take a much broader look, you realize that it's not because of the odontoid fracture, because this population of patients above the age of 65 or 70 years of age, they have a high mortality rate anyways with any kind of fracture that you get. Even with a stupid rest fracture, they have a 4% mortality rate. So it's not really about the odontoid fracture, it's the fact that this population of patients is really frail and they are liable to more morbidity and mortality as well. I get asked all the time about the use of soft collar in odontoid fractures, and my answer is yes, there is a rule to use a soft collar, particularly in those patients who are elderly, debilitated, they don't have signs and symptoms of myelopathy, they cannot tolerate that hard collar, so those are the ones who can probably get away by using a soft collar. So my recommendations for the elderly will be, if you have a stable type 2 or type 1 and type 3, use a hard collar. If it's unstable type 2, use a posterior C1, C2. Try not to go anterior with them. And obviously, if you have a debilitated patient, you can use the soft collar. But no matter what you do, don't ever use a halo in the elderly, because you're going to end up with a lot of complications. So if we decide to operate on those, one of two options, obviously to go anterior versus posterior, and let's start by talking about the anterior approach, which is screws. I would say reserve those to younger patients that have better bone quality. The most important thing is your landing point. So you need to make sure that you land in the C2-3 disc space, not to land anterior as the picture on the right side, because that can end up with you having a cut through or failure of your fixation. And we already know very well from the literature that obviously they don't work. You have a very old fracture, or you have a fracture that already has healed cortical rims on the CT scan. Obviously, that's not going to work, right? And that's the rule with any fracture in orthopedics in general. Now, it's important to highlight that what we're looking for is not healing of the fracture, or not that bony union. We're looking for stability. Because if you look at the literature, you realize that the bony fusion with odontoid screws is somewhere around the 60%, and the fibrous non-union is somewhere around 24%. But even that fibrous non-union is stable enough, particularly for the elderly. So it's not the idea of having a bony fusion versus non-bony fusion. It's the idea of having a stable situation versus an unstable fracture on the flexion extension views. And that's the most important thing, because the majority of the time that fibrous union is enough for the elderly as well. Now, one versus two screws, and I get asked this all the time. Well, I always aim for two screws. I end up getting one screw only in place. I don't know why. But obviously from the literature, if you're using two screws, you have better stability, because you're killing the rotational instability part of those fractures. Now, very important to highlight that these surgeries are not complication-free as well. And probably the most common complication is dysphagia in the elderly. Mortality is still part of the complications that you can get, particularly with cardiopulmonary complications. But it's something to keep in mind whenever you're dealing with those. Now, if I'm going to show you those three fractures and ask you which one is contraindicated for odontoid screws, and if you guessed the number 2 fracture, you're completely right. This is what we call reverse obliquity, because you basically cannot have an odontoid screws that's perpendicular to the fracture site. Also another contraindication patient, if you have one of those barrel chests where it's very difficult to get that trajectory with your drill bit, then this is probably the one that you should go posterior and avoid going anterior for those patients. Now let me show you one of the cases here. This is a case that presented to us with a type 2 odontoid fracture. Those are her pre-reduction x-rays. We did a CT scan for her, and you can see that it's a fracture that's totally displaced. This is a patient that we elected to put a halo collar, and after putting the halo for halo vest, and after putting the halo and doing 3 trials of reduction, she failed that, and eventually we elected to take her to the OR and put an odontoid screw, and you can see here 2 months that she maintained to have a very good reduction, and she had a very solid fusion or healing of the fracture at 6 months with a normal C1, C2 motion, which is the advantage of going anterior using an odontoid screw. Now, if we move to the second surgical option, which is obviously going posterior for a C1, C2 fusion, and the thing here that we know the major advantage of going posterior is obviously your fusion rate, right? This is somewhere in the above 95%, which is a huge advantage of going posterior. Now, very important to highlight as well that we also know from the literature that particularly in the elderly population, if you decide to go for surgery, try to go for surgery as early as possible, because that can be protective for these patients against mortality. So it's something also to keep in mind when you're dealing with this. Now, it's important to highlight as well that it's not a complication-free surgery. It has its share of complications, even dysphagia, which is very interesting. So despite the fact that you're going posterior, not doing any anterior approach, you still can get a 30% dysphagia rate in those patients. And what's even more interesting is that those patients who ended up with dysphagia over 15 times had a chance of mortality within 1 year post-op. So it is something serious, and it is something that can happen with both anterior and posterior approaches. Now, so what comes out of this is that if you take a look at the paper by Gregory Schroeder and Alex Vaccaro that was published like 10 years ago, you realize that there is no difference in the mortality and complications whether you go anterior or posterior. So I would say if you have very bad fracture trajectory that doesn't meet the criteria of an odontoid screw, or the elderly, then you probably go posterior. If you have a younger patient, go anterior, but your complication rate is going to be the same whether you go anterior or posterior. Now the million-dollar question: is surgery protective for patients with odontoid fractures? And we're talking here about the elderly. So once again, if you take a look at the literature here by the paper by Mitch Harris, you realize that in patients who are in the 60s and 70s, surgery was found to be actually very protective against mortality, right? So those operated patients had much lower mortality rate and morbidity in comparison to those who were not operated. But it's very important, as I said before, to define what an elderly patient means, because if you take a deeper look at the literature, you realize that in patients who are octogenarians, who are above the age of 85, surgery didn't show any difference in the outcome of those patients. So whether you operate or not operate on those patients is not going to make any difference. So you should proceed with surgery with fear. So bottom line is, surgery has a protective effect in patients who are in their 60s and 70s. And it doesn't have that same protective effect in patients who are in their 80s and 90s. And that's why the definition of the elderly population is very important, because not everyone above the age of 60 is an elderly. And we've seen from this study that the protective effect of surgery differs from the 60s, 70s versus 80s, 90s. So back to our case here, who was a meth addict at 59 years old, female patient who was involved multiple collision. This is a patient that we took to the OR and we basically reduced her over the halo that she had using a bivertical traction that was described by Dan Rue, and we published that in the International Journal of Surgery as well. And we ended up having an odontoid screw. And as you can see here, my landing point for the screw was actually anterior. That's not perfect. You should always aim for that C2, C3 entry point of the disc space. But she did fairly well, obviously for the amount of follow-up time that we did see her in our clinic. So bottom line is, patients are getting older. We're going to operate on more odontoid fractures in the future. You're going to get your best fusion rate, obviously, with the posterior approach. Surgery is protective for patients who are in their 60s and 70s. It doesn't make much of a difference for patients who are in their 80s and their 90s. And obviously, tailor your decision of surgery based on individualizing the treatment for every single patient. Thank you very much, and I wish you a very productive meeting, and hopefully we can meet next year face to face.